Hello, Dr. Roberts, or Stacey, you said I should call you. Welcome to the podcast. I'm really excited to explore the topic of shockwave therapy with you. This is something that's being I saw it first being talked about in the men's health realm with regards to erectile dysfunction, but I'm seeing more and more of it addressing female pelvic health challenges as well. But before we get into that topic, I would love for you to tell us a little bit about yourself, what got you into physical therapy and specializing in pelvic health, and then what brought you down the path of shockwave therapy.
Sure. So I'm a physical therapist of over 30 years. I got into physical therapy, actually pre-med. So I got into physical therapy after I tore my ACL playing college athletics, and through the process of developing a relationship with my PT, I'm like, hey, this is kind of cool. The orthopedic surgeon I'm only seeing like 10 minutes, once every 3 or 4 months, where I see this PT, 3 times a week. And I thought sports medicine was really cool. So I changed my major into physical therapy at that time from pre-med. And then, I worked at a hospital, then branched out into sports medicine and ortho, did a sports medicine fellowship, moved to Australia in 2000, where I had a clinic that was focused more on women's health, and then started to get more into women's and men's pelvic health and fertility. And so that's kind of how I branched into the male and female sexual health then as well too. When I moved back to the U.S., back to the Milwaukee area, I was working as a director for a large company, and I was like, this just isn't me. Want to have my own clinic again. I opened 10 clinics for them. I'm like, why am I doing this for somebody else? So I opened my own clinic, and then following my passion, because while I was in Australia, I did a lot of functional medicine too, and more holistic care, became a master herbalist over there. So I have my foot in both conventional and alternative or holistic medicine as well too.
That's very cool. I think that's always how I think medicine should be done. I think it would be done best to have this complementary approach.
Right.
And there's a little bit more of that now with the two.
Yes.
Well, it's not even just two, but the different sides talking to one another a little bit more. So I just think that that's such a beautiful way to manage people's bodies and health conditions and concerns.
People are craving that. They really want that. So it's, we're of the generation of wanting to be healthy and active, and sometimes conventional medicine isn't the way to go for that. It doesn't satisfy our needs there. So we start looking for other processes that can be done, or other interventions. So I think, and then the next generation is learning more about, taking care of the health a lot earlier than like what I learned, for example. So I think people are definitely wanting that type of approach.
Yeah. So what brought you to, you've opened up your own clinic, you brought the sort of the complementary approach that you have been doing. And then where did the shockwave piece come in? So before we explore kind of what is it, but how did you get introduced to it, and why has that now become a main focus of your practice?
Sure. So when I first moved back to the U.S., I started seeing people for fertility issues, but here in the U.S., people kind of couldn't put together how a physical therapist knew anything about fertility and hormones and things like that. So as I went back to work as a PT, I still was missing my passion of working with, holistically working with people. So I thought, what could I do? How could I do this? So I decided to go back to school for nursing, get my master's in nursing, and then eventually become a nurse practitioner. So to expand my scope of practice. So when I did that, a friend of mine, I was probably halfway, 3/4 of the way through my program. So during COVID, and a friend came up to me and said, I found this Shockwave device. It's a guy has it about an hour and a half away. Do you think it would help my shoulder? And I'm like, nah, probably not. I've seen it all. I haven't really heard of Shockwave at that time, but I'm like, no modality. That I'm very much of a manual therapist. So no modality really ever moved the needle or was a big game changer for my patients. So I just tended to stay away from them. But, I had treated her before. She had calcific tendonitis. So at end range of shoulder motion, she would have pain still, but it wasn't a functional issue. It was more like if she slept on it wrong, that type of thing. So I agreed, because of a free lunch, to go up if she had a session, just to make sure it was safe. Like, I didn't want her to do anything that it was unsafe. So we went up. She had the treatment. I was curious as the guy was doing it that even though she wasn't moving her arm, when you go over an area, especially that has bony prominences, it will help you to kind of determine where inflammation is, and they could tell exactly where the calcific tendonitis was, which was really interesting. And then after the session, she raised her arm and she goes, it's gone. And I'm like, all right, well, I'll talk to you in a couple of days. I'm sure it's going to be back. I mean, it's a fluke, that type of thing. Days go by, weeks go by. She still doesn't have any pain. As a matter of fact, 2.5 years went by till she had pain again when she was playing pickleball. Now, that doesn't typically happen. So I think serendipitously I was meant to see that so that I would jump into the research. I'm like, what is this? So then I started getting into the research, and it was so confusing. All the different devices, all different outcomes. So again, the way my brain works is, okay, this is challenging. I want to learn about it. If this truly can be something, someday I'll want to put it in my clinic, right? When I become an NP. So I did the research, started answering different questions that people had on different forums for pelvic health. And Holly Tanner, who is an educational director and an instructor for Herman Wallace, reached out and said, hey, you kind of know a lot about Shockwave, and it's relevant and, good research. She's like, where'd you learn all this? And I said, basically by digging myself. And she's like, maybe you should put a course together for Herman and Wallace. So I put a course together for Herman and Wallace for Shockwave for PTs, demystifying the research, because again, it's so confusing. So it took me 8 to 10 months to learn. I've compacted into 4 hours with Herman and Wallace. So that's really kind of how I got into Shockwave. And then I decided, because I'm a crazy person, that instead of waiting until after I got my NP to open a clinic, I would do it at that time when Shockwave was presented to me. And so I still have my clinicals to finish for my NP, but I'm busy, crazy busy in my clinic. And I moved from ortho into pelvic health with Shockwave, Softwave in particular, because I thought, look, it increases blood flow to the muscles. It increases the anti-inflammatory molecules, stem cells, M2 macrophages, upregulates toll-like receptor 3 related to regeneration. Why can't we do this on pelvic health issues? There were a few studies out there. So then I did it on a patient who had vaginismus, and I kid you not, Kim, you've dealt with vaginismus. You know how it's a tough thing to treat, especially manually, because it's so darn painful, right? And there's a lot of biopsychosocial aspect to it. After the first treatment, the patient and I were both, I'll use a term from Australia, gobsmacked, because I was able to do a full internal after the treatment, and she had minimal pain. Prior to, I barely could do an internal. The muscles were like butter. What's nice about treating the pelvic floor is the increase of blood flow is immediate, and so you can get that relaxation, and then you can do a little bit more manual therapy. So she, after not having intercourse for 5 years, was having intercourse with her partner after 3 or 4 treatments. Which, again, exactly. You know from treating people that's so unusual. And that's what then moved me into doing the dyspareunia study, where I'm a co-principal investigator. Myself, Holly Tanner, Heather Jeffcoat, and Stacey Futterman around the country are utilizing this with PT, because we want to show, we already know PT works for dyspareunia, vaginismus, those things. But we want to show that this can accelerate the progress, because that's what patients want. That's what they like, right? And I don't like hurting my patients either. So if I can make them more comfortable and my manual therapy is more efficient and effective, why wouldn't I want to use something like this?
Yeah. Okay. So many questions. I want to start though at the beginning. If you look up Shockwave, and especially if I look up you see Softwave, and you even just mentioned Softwave. So can you first distinguish what is Shockwave therapy, and what is the brand, or where does Softwave come in?
So there's 3 different types of true Shockwave: electromagnetic, piezoelectric, and electrohydraulic. Softwave is the name of the company, and they produce an electrohydraulic device, which is a little bit unique, and I'll get into that later. But in the research, what you have to be careful of is when you look at Shockwave, also something called radial wave or radio pressure wave, EPAT, those types of things are also under the Shockwave umbrella, even though strangely enough they don't even produce Shockwave. So I don't know, from the International Society of Medical Shockwave Therapies somehow included them under the umbrella. Maybe at some point they thought they produced shockwaves, but now we know that they don't. That the radial devices are more like a jackhammer on the skin, and it's not something that I have utilized on the perineum or any in that area, just simply because that significant microtrauma and pain that it can potentially cause and does cause when you're treating a typical ortho condition. So when I'm talking about shockwave, I'm not relating to radial. It's even the measurements are different. Everything is different about it. So true shockwave is the electrohydraulic, piezoelectric, electromagnetic. As I said, Softwave is electrohydraulic. But the other
Okay.
differentiating factor, and what that I liked when I tried all the different devices, was Softwave's applicator the energy comes out of it more like a flashlight. So if we think of Shockwave in general, it first started as lithotripsy in hospitals around the world to break up kidney stones. It was very, very high intensity, highly focused shockwave. Needed to be able to break up those kidney stones non-surgically. Then while they were doing that, they found that there were changes in the vertebral bodies while they were doing this high intensity, and they noticed that it had some effect on bones. So they started treating non-healing, non-union fractures that were resistant to healing, and with it could have been 6 months or more. And then they started doing shockwave on them, and lo and behold, they started to heal. So that then went from there into treating tendinopathies, tendinitis, things like that were more superficial. And then kind of ED jumped in because we know it increases blood flow. So they utilize it to increase blood flow to the area. It also increases nitric oxide. Now, there's a lot we can get to talk about that because typically it's just the penis that's being treated and that's it. But as you know, pelvic floor has a lot to do with that. The hips can have a lot to do with that. Pudendal nerve could have a lot to do with it. So there's other areas that could be treated. I landed on Softwave because of the fact that it doesn't come out like a laser. It comes out more like a flashlight, which is more like a shockwave in nature, like a volcanic eruption. It comes out like that. And it's more comfortable for the patient because it's not laser beam focused. That is low energy, so not the kidney stone treatment, but they found that low energy is effective for orthopedic issues, tendinitises, tendinopathies, things like that. And we use low energy in outpatient because you don't have to, there's no anesthetic, things like that. So my patients have found when I tried all the different machines, my patients found Softwave to be more comfortable. I found there were less shocks needed in comparison to the other devices out there. So that's the one that I went with, and the treatment times are shorter as well because less shocks are necessary. So that's why I landed on Softwave, which is the only one that
Got
has
it.
this unique applicator.
Okay. So now to get to the elephant in the room, when you hear shock, obviously you think pain and shocking. And
Right?
so what does it feel like when you have, what does a treatment look like
Yep.
with we'll focus you, as you say, you use the soft waves. So
Mm-hmm.
you've talked about a flashlight. I am envisioning there's some sort of probe that would be delivering this energy to the tissues. Is that
Absolutely.
accurate?
Yep, that's accurate. So the Shockwave device, the one that I have, it's kind of a rounded dome. I could kind of bring it over here if you want. I don't know. Do you want me to show it to you? I don't know from a
Sure,
podcast.
if you have it. Yeah,
Yep.
we will put this on
Okay.
YouTube.
If
So
I
yeah.
can move this over. Sorry, I should have had that set up for you beforehand. See it over there.
Yep.
Got it. So probe looks like this. And
Looks like a big flashlight.
yep, exactly. It's like a big flashlight. So it comes out like this, right? Whereas the other shockwave devices come out like a laser. So they were kind of mimicking the lithotripsy, coming out like a laser versus coming out like the flashlight. So that's what this looks like. I don't know if you could see it on camera, you can probably hear it, but you'll see some flashes. That's an
Yep.
electrode inside there creating those flashes of light. That creates a sound wave that goes through the tissue. The patient will feel a tapping on the tissue until you go over an area that is inflamed, whether it's a trigger point or let's say an arthritic area around a bone or the end of the bones. And then they'll be like, "Ooh, yeah, I can feel that." And then you turn it up to what they tolerate. And then, which is the crazy part of it is during the treatment, the pain actually goes down. So that
Wow.
immediately after the treatment, they're usually 50 to 100% better. And unlike my friend who had one treatment and it was amazing for her for over 2 years, most people need to come back like once a week for about 3 to 4 weeks. After the 3 to 4 weeks, unless there's significant complications from many areas that need to be treated, after 3 to 4 weeks, they should be 50 to 100% better. So in the perineum, they may not have any pain whatsoever. They just might feel that tapping, might feel the wave coming up. If they don't have a uterus, for example, if you're treating a female who doesn't have a uterus, it can come up and they might feel it around their belly button, almost getting that high. they have a uterus, they'll feel it potentially coming across towards the ovaries. Men will just feel it if, men sometimes can't feel anything really sometimes as we're doing stuff, the disconnect with the body. But if they feel it, it will also kind of feel like a wave going through their pelvic floor. So it's an interesting, people don't describe it so much as pain unless you crank it up, and there's no need to turn it up very high. They'll describe it as more of a sensitivity.
Got it. And how long does a treatment session last?
So for electrohydraulic devices like Softwave, anywhere between 8 and 12 minutes-ish. For electromagnetic and piezoelectric, because they have to use more shocks, probably anywhere, the average number of shocks used for electrohydraulic is about 1,000 per session. And then because the laser beam, piezo and electromagnetic, they have to move around a lot, and you can fall off the spot that you really want to treat. There's a lot of kind of, not, I don't want to say guessing, but just a lot of moving to find and stay on that right spot. So that could be 2,000 to 4,000 shocks. So that could be, 15, 20, or 30 minutes, depending on, what you're treating and how many. So there's another factor for me is the electrohydraulic was a shorter treatment session, and it also decreases my manual therapy. So it makes it more effective, and it decreases the amount of time that I need to do it. And it's a lot less painful for the patients, which is amazing.
Yeah, well, that was the point I was going to say, is it reduces, but it also even opens up the opportunity for manual therapy in some people.
Right.
Yeah.
Yeah.
Interesting. Mm-hmm. So let's talk a little bit about what conditions. Mm-hmm. Yes, erectile dysfunction is where I first heard about it, and now it's being explored. And you can talk about all the different. You've talked about vaginismus, dyspareunia. So what are all of the conditions that somebody could potentially experience that could benefit from a Softwave or a Shockwave treatment?
So any orthopedic type of soft tissue injury or chronic issue. So if we move into from pelvic floor point of view, we can vulvodynia, vestibular dynia. We could treat like we talked about, dyspareunia, vaginismus. ED is different because we're not treating like a pain, like there's not something specific. We're really, the goal there is to increase blood flow to the area, right? Increase nitric oxide to relax the smooth muscle of the penis so that the more blood flow can get into the penis to help it become erect. So it's a little bit different and requires a few more, couple thousand more shocks just in general because of that. But really, I mean, lichen sclerosis, it's not going to cure lichen sclerosis, but it's going to decrease the lesion size very quickly because it has a really nice improvement on wound care as well. So they'll find that the itchiness and the soreness decreases significantly. What else? Throw out another diagnosis for me and I'll let you know if it...
I'm thinking people who have, maybe they don't even yet have a diagnosis of vestibular dynia. They have a tight pelvic floor, or they say they have burning in their vagina, or they have tightness. So people who have been told never do Kegels and just focus on relaxing the pelvic floor. Is this something that could come in and play a role?
What's nice about it is you know the type of person that comes in and they have no idea what you're talking about when you say relax your pelvic floor or down regulate, right? Down train. They just don't have a concept, right? So what's nice about this is because when you treat the pelvic floor, you bring blood flow to the area. Now there's feeling there, right? So now they can even feel. The guys especially will walk away and be like, it's kind of warm down there. It kind of just feels warm. So now some have this connection, this sensation that they feel. And then we can start giving them a little bit more they've got the biofeedback. We can give them more feedback. Then they can kind of understand even where those muscles are, right? Most people have no idea there's even muscles there. It's better now with more focus on pelvic therapy, but in general, there's a disconnect, right? So it absolutely will help with that. And then with coaching and PT and going through, how to contract and relax down train, what that means, how to move and the functional aspect of pelvic floor therapy. It just helps to enhance what we already do. It accelerates the process for the patient and the practitioner and makes what we do more effective and efficient as PTs. Mm-hmm.
I'm now thinking in my mind, because you said wound healing, if you think about postpartum or post-op, so post-pelvic surgery or, again, postpartum, whether if they've had tearing or whether they had an episiotomy, cesarean.
This is
Is that a place you could start using it?
absolutely, and there's some exciting new research that's just come out of that. But the women involved in the dyspareunia study are so excited to when we finish that study, we want to do scarring because postpartum scars, C-section scars, episiotomy. I mean, all those things just work so well with this. The tissue heals so well, and we minimize the scarring. They're using this in aesthetics too after surgeries. It minimizes scarring and minimizes pain, chronic pain around scarring. I've treated several patients now where during the treatment they're like, and we're like, "Are you okay?" And they're like, "Oh my God, yes, this is the first time it's felt better." Like when the pain goes down during the treatment, they're like, "Oh my God, like this it's the first time that it's ever, changed, right?" So it really is extremely rewarding to be able to see that happen much more quickly than it typically would happen in a regular session. So yeah, and the new research that I was alluding to, I was just in Amsterdam at the International Shockwave conference out there, medical shockwave conference there, and they're actually saying that by doing shockwave to the scars, even if it's been long-term scarring, it's changing the cellular structure of that tissue. More stem cells are coming there, differentiating into healthier tissue, improving collagen.
Wow.
I mean, it's fascinating that it's kind of reversing that process of we typically think of scars as dead tissue with no blood supply, right?
Right.
And then our nerve entrapments, right? So
Yeah.
it really significantly helps to improve that blood flow to the area, and then helps with that pain response as well too.
So what about pudendal neuralgia?
Great question. So, how sometimes we're like, is it pudendal neuralgia? Or nice thing about this is it has that biofeedback mechanism so that as we trace the pudendal nerve, if they get the referral to the genital area, we can be pretty confident that the pudendal nerve is involved, right? So by understanding our anatomy, if somebody comes in with sensitivity or numbness or pain, if we trace the nerves that we know that are innervating that area with the Softwave device, and that creates their symptoms, and we know we're on what we call a hotspot, and then by treating that, usually the pain will start to go down during the treatment. But like anytime you're treating a nerve, you have to be a little bit more sometimes gentle or work the tissue around it, right? So it's great to bring blood flow to the tissue around it as well. We can do manual therapy. So it, again, just really enhances that and minimizes the inflammation around the area if there's inflammation around the nerve. A lot of times, like with stress incontinence, the blood flow to the striated and smooth muscles of the urethra and the bladder are affected. And what they find when they utilize shockwave on patients who have stress incontinence is simply by bringing blood flow to those muscles, they can work better without doing any strengthening. Right, the mucosa improves as well in those structures as well too. So we're decreasing inflammation, we're improving blood flow. So now a muscle, if I contracted my bicep, I mean, I can't really move it if I don't have any blood flow to it, right? So just continue contracting it, pushing all the blood, or it's from disuse. There's not really much blood supply there. You start adding blood flow to that area, and okay, I can use that bicep, right? Same thing for that urethra, those structures in the urethra, the muscular structures in the urethra as well too. And then again, if they do need strengthening, if that's an aspect of the program, there's blood nourishing those structures to be able to allow them to work.
Yeah. That was another question I had was the prolapse and incontinence categories. Are there any benefits to those people? So this is, as you're saying, increasing blood flow. That, of course, my mind is going to the people who are like, what? I wouldn't have to do exercise? Great. I'll just do a shockwave treatment.
Right. Yeah. But, and then, it's only going to last, right, for so long. And sure, they could do a shockwave treatment or they could do their exercises, right?
Yeah.
So we want to be sure, and again, it's the same thing with PT, right? Right. See, they're feeling good for a while and then they stop doing their exercise because they're feeling good. So
Exactly.
none of that goes away of counseling and having patients, take accountability and responsibility for what they need to do afterwards. But it certainly helps to helps to show them that this can be something that's addressed. Now, prolapse it's not going to correct a prolapse. So if there's a prolapse, there's torn ligaments, things like that. It's not going to reconnect ligaments by any means. If there's partial tear, it can help with improving that remaining connection. But the pain associated with prolapse, if it's not more structural, and then from a functional and biomechanical point of view, even by increasing the blood flow, we might get some reduction in pain. But prolapses are a little bit different animal than just, typical pelvic floor issues.
Yeah. And my mind is also going to levator avulsion, which, there is an element where it's not going to reattach the muscles, but what's the surrounding structures, what's remaining, can we increase blood flow circulation to help potentially minimize some of the ongoing lack of function,
Correct.
Progressive lack of function. Yeah.
Correct. Mm-hmm. Exactly.
Yeah. Interesting. When you showed the sort of the flashlight type thing there, it almost looked like a crystal ball with, a roundness. And so, it's like a jelly. Okay. So you press on it. It's like a jelly. Okay.
So there's water inside here. So when I press on it, I'm pressing against water over like that flashlight on the top. And then the electrode is inside there. So this is the electrohydraulic part. And it's a closed, Softwave has a closed system. Other systems out there are open where you pour the water in yourself. They get rusted relatively easily. This is a nice closed system, and the pressure is very reliable. We know what we're getting each time we're using it, that type of thing.
So is that placed directly on the skin? It's in direct contact with the person.
That's correct. And a nice external treatment for those who aren't sure about internal, right? So we can actually get to the pelvic floor with this. Electrohydraulic devices will penetrate up to 4 to 6 inches. And what's nice about, again, Softwave is that it's a flashlight, so it's not just going straight in, it's also going out, right?
Expanding out, yeah.
You're getting all 3 layers of the pelvic floor can get treated with Softwave, which is really nice. And that's why you get that overall relaxation or significant improvement in blood flow where it literally is palpating like, until you palpate it, you don't believe it. Like, I wouldn't believe it if I didn't palpate it. And I'm like, oh my gosh, they're like butter. So that's what, again, is that particular applicator makes it much more comfortable just sitting on the perineum versus the other applicators you got to move in order to try to hit all those areas.
What about menopause, post-menopause, potentially somebody who's well post-menopause who was not advised of vaginal estrogen, or there's been a lot of atrophy? Is there, again, it's not necessarily going to miraculously return the vulva vagina to the previous state, but could it help potentially reduce some of the atrophy that has occurred? The lack of blood flow circulation obviously is going to be a yes, but even like dryness, do you think that there could be
improves the mucosa as well, mucus production for sure. As you alluded to, hormones would need to be addressed in some way, shape, or form. Whether if they're extremely postmenopausal, like long ways past menopause, then looking at adrenal function too, because that's where estrogen, progesterone's only produced after the ovaries are not producing them anymore. So in conjunction with other things, whether it's topical estrogen or herbs and lifestyle changes to improve things as well too, in combination, you'll see that increased blood flow. You'll see the improvement in blood flow in those vaginal tissues in the vulva right after treatment. So they will look much better. Now, keeping them that way is obviously something that, how many treatments do we need to do with this? Is something that maintenance is required? That's other research that is being done now, and that we're trying to pioneer as well too for women's health, because as you know, like everything else, there's much more men's health research, right, than there is women's public health research. So we want to really see what is a great combination for women who are having those issues. Can Shockwave move the needle in combination with these other therapies? So that's where my goal is to keep moving and progressing that research for women's health.
With regards to, again, this could be really, it's pretty much whole body, but I'm staying in the pelvis, and for hip, so hip, knee, tailbone, like other areas where there could be pain and inflammation, pubic symphysis. So let's say if there's somebody who is having some hip degeneration or hip pain, which can then indirectly influence the pelvis. So that's also another place application.
100%. So if there's inflammation somewhere else, restricted motion, function, those types of things that's affecting the pelvic floor, absolutely. So I tell physical therapists to think about this as an extension of their manual therapy, right? So everything that we would normally do, we would assess the pelvis. If they have tailbone pain, we're looking at lumbar spine. We're looking at pelvic torsion, all that type of stuff, right? None of that changes. But now we have a tool to kind of pinpoint and narrow down where the inflammation potentially is that we can treat, where we can treat to help us improve our manual therapy as far as its efficacy and efficiency. So to answer your question, yes, so we could treat the hip. Maybe there's some capsular issues there. This gets deep enough to get into the capsule to make the capsule more pliable, shoulder and hip, whichever we're working on there, frozen shoulder, all that type of stuff. So to answer your question, yes. And we just need to put on our PT brain to, because some places you go and they just go, it hurts here, and that's where they do the Shockwave.
Yeah.
So, I mean, if it hurts on your knee and you put it right on your kneecap, 9.9 out of 10 people aren't going to have pain on their kneecap. And they're like, oh, that's where it must be from. Well, no, it's because you're banging something against the kneecap, right? But if you understand anatomy, and then you go, okay, well, where's the joint line? Where is this going? Does the patient feel it deep or superficial? Again, it's just enhancing what we should be doing in our assessment and treatment of anybody with pelvic floor dysfunction, bringing in all of those areas as well.
Right. And back to the treatment itself, you've talked about the perineum, and different from other types of shockwave that might be more kind of, as you said, laser and require movement around. With the is it accurate to call it the probe?
Probe, yep.
The head,
yep.
Yeah. So the probe piece, would that then, you're putting it onto the perineum, and are you holding it there for the 8 to 10 minutes the entire time, or do you remove it and apply it, or do you go around the external tissues around the vulva?
So with this device, you basically put it where you're wanting to treat it. You're thinking about how it's coming out like a flashlight, and then all you do is kind of angle up, angle down, angle to the side. I might move it up a little bit more it can be uncomfortable directly on the clitoral hood, so I'll treat the clitoris laterally and try to increase blood flow to that area as well too. There's typically very little movement of that in that area, and you're just chatting with the patient and being like, okay, what about this? Do you feel it here? Again, same thing, same process that we would do with manual therapy, right? So and it's a very easy, very straightforward technique to do, which can, if you have a PTA or if a physician has technicians or MAs or whatever, as long as they have a decent knowledge of anatomy, and that I believe the practitioner, the provider should do the first treatment. So they're understanding where this person should be treated so that person can get the best outcome. I've heard of places doing their front office person is doing Shockwave because it's that easy to do. But are they really going to be able to make the clinical decision of where do I move this next, or what do I do here?
Right.
So the outcomes, we want for the patient to be the best. So that person that's well trained can really make a huge difference with this.
Right. And I apologize, I think you have said this, but if you can reiterate, the 8 to 10 session, and then everybody's going to be a little bit different. Some people, like your friend, had that one treatment, it was fine for 2.5 years, but the general person requires how many sessions over what period of time?
So if we look at a typical pain diagnosis, that is, let's say, doesn't have multiple areas that we have to treat, right? It's relatively straightforward. We're looking at 3 or 4 treatments over 3 or 4 weeks. If somebody has chronic issues, they come in and they've had this issue for 20 years, it's on and off, it's now worse, it gets better. Those patients might need 6 to 9 treatments, but not necessarily weekly. So they'll usually, if it's going well, and if it's only this issue, like from a functional medicine standpoint, I tell my patients, if this isn't better by 50 to 100% in 3 to 4 visits, we need to talk about other things. We need to talk about your gut health. We need to talk about your hormones. We need to talk about your diet. We need to talk about different things that could be contributing to inflammation. But typically by that 3rd or 4th visit, we know for sure that they're moving in the right direction, that this is more localized inflammation that we're dealing with, not systemic, and that we can keep them moving the needle. Then we start going, okay, well, you're feeling great since I saw you last. Now let's go out for 2 weeks. So that 4th, 5th, and 6th session might not be weekly, that might be every 2 weeks or 3 weeks. And then some of my patients, and especially ED patients, will come back for monthly treatments as kind of a maintenance program,
The
right?
maintenance, yeah.
Especially if they've had a problem for a long time. But now I'm running into, after I have to add different services to my membership plan for monthly treatments, because like by that 6th month, they come in and they're like, I don't even know what to treat. Like, I feel really good. And I'm like, oh, okay. What else can we do? Any other problems?
Yeah.
So now I add like a personal training session instead, like if they're feeling good. So it's enabled me to add a membership program. Now I just have to be more creative because their patients are feeling good, which is a good problem to have.
Yeah. That's cool.
Mm-hmm.
There was one other, when I was looking into the research and the technology, there was high and low intensity extracorporeal.
Yep.
Or is that, if I've pronounced it correctly? What does that mean?
So extracorporeal shockwave therapy means, basically on the outside of the body, right? And that encompasses all shockwave. Okay. Then there's high intensity, which is the lithotripsy, used in hospitals, usually need to be under anesthetic. And then there's low intensity, which is used in the outpatient clinics. So those are what you would see in your PT clinics, your OT clinics, your chiropractic clinics. That's the low intensity. The others can cause significant damage. That's why they break up kidney stones. High intensity break up kidney stones, break up calcific tendonitis if they're using it for that. Low intensity, the piezoelectric and electromagnetic and the electrohydraulic devices that are not that have the different applicator that are only laser. They work on the adage that they're creating microtrauma, restarting that immune process. What's interesting with shockwave research out of Austria and Germany is that, Softwave research out of Austria and Germany for that particular product is that, or that particular machine, there's no evidence of microtrauma. So just by stimulating the cells, the shearing force of that wave coming across the cells, making the cells contract and expand. I talk a lot about this in the Herman and Wallace course that I have. The cells contract and expand, and that's sending the signals. It's releasing exosomes from other cells to go to that area, sending signals to the brain. M2 macrophages are going there. The body treats it like, what's going on down there? We need to send some reinforcements in to investigate. And then, stem cells go to that area as well, too. So we're helping with inflammation and significantly reducing pain.
Mm-hmm. Yeah, and so you've kind of explained it there. Like, what's the mechanism of action, which is, so it's inducing something for the immune system to recognize and
Correct.
the body to recognize and come in and respond to.
Yeah, they call it mechanotransduction if you read up on shockwave, which is basically it's stimulating the tissues. Then there's a chemical effect as a result of that. Then there's the biological effect as a result of that, which is really just supporting the body's own innate healing process, right? So, somebody has a chronic issue, we know that, that the pain pathways kind of change, right? So now it's not necessarily a lot of inflammation there, but there can certainly be, but there's messages from the brain that are still reinforcing that pain. So even helping to break that cycle up by decreasing the pain in the area, it has a lot to do with what's going on in the brain as well. Definitely more research needs to be done there, but we have had patients treating Softwave, or did some research on a long COVID study. I think they're presenting this at the APTA next year. Long COVID and treating Softwave on the brain, in the brainstem, to increase perfusion to the brain, and brain fog is going away. People are feeling more energetic, that type of thing too. So there's so many applications. It's like too good to be true. Like every time I'm like, really? Like another thing that I can do? People are never going to believe this works because, we say so many things. They use it on the open heart. Like a new study just was published in Europe on using, and Softwave happens to be the company that was doing this, putting that on the open heart after open heart surgery before they close them up to decrease inflammation. They're finding that increases ejection fraction, doubles ejection fraction from just having a normal CABG surgery. And also in another study that's yet to be published, it decreases opioid use by up to 40% and some 20 to 40% depending. I mean, because of that anti-inflammatory effect, I mean, the possibilities are endless,
Do you know of any, have you treated anybody, or do you know of any research with regards to endometriosis or adenomyosis?
Yes. So I've treated patients with that. Now, what's really interesting is, it can be difficult to, well, some women don't know if they have it, if they haven't had laparoscopy, right, to absolutely confirm it, or if there's no hemorrhagic cysts that they have seen on ultrasound, stuff like that. So, but what's interesting is I've treated patients who, I'm usually getting the really bad chronic cases because nothing else is working for them. So when we go over the areas of the lesions or where we think the lesions are, some patients will get like this, automatic nervous system response. They feel dizzy, they feel lightheaded, and then that response also decreases with treatment. And then I can get in there and do some good visceral work. If they've had surgery, do some work on the internal scarring that's going on there too. And there's a wonderful OB/GYN, Dr. Mary Ojo Cardins, I think, in West Virginia, and we're doing a pilot on patients that have suspected endometriosis to see what's the right protocol for this, right? Because again, this is new. We don't know for sure. So we want to try to establish the best protocol for those patients coming in. I've treated dysmenorrhea as well too, with it really significantly decreasing the inflammation during the period and after. We have seen some changes in menstrual flow as a result of utilizing it. Kind of makes sense. We're increasing blood flow to the area, right? And I was hesitant to use it with endometriosis because I was afraid, what if we increase blood flow to the area and that makes it worse? But what made me feel better about that is I also was hesitant to utilize it on hemorrhoids. I had, this might be too much information, but I had a history of hemorrhoids, and I'm like, okay, I'll try it on myself and see. And sure enough, during the treatment on hemorrhoids, you'll get kind of an itchy feeling. Instead of pain, it's more the itchy, and that itchiness goes away during the treatment. And I literally haven't, in 3 years, haven't had an issue with hemorrhoids. So that's bringing more blood flow to an area that you think, oh gosh, there's already like too much blood flow and causing pain.
Right.
The anti-inflammatory effect of what's happening is helping those hemorrhoids reduce and not become. This is anecdotally my theory because there's no study yet that shows this, but in the patients that I've treated with it, everyone is the same in regards to improvement. So endometriosis, in my mind, similar, right? Where it can bring blood flow to the area to decrease the inflammation around those lesions so that potentially, fingers crossed, there's minimal pain. And I haven't had somebody who's like, oh my God, I have absolutely no pain now from my endometriosis, but it has significantly reduced the pain in many cases.
Wow. What about, speaking of hemorrhoids, so hemorrhoids, what about mucosal prolapse, rectal prolapse? We've kind of already touched on the prolapse piece of it, but it's a little, sometimes a bit more nuanced in the anus.
Yeah, exactly. And that brings me to, there could be a lot of things going on, right? So whenever somebody says, can it help with this? The first thing I say is, what are you trying to accomplish, right? We're not going to take the prolapse away. But if we can, like we alluded to before, if we can work on the tissue around there to solve and decrease pain that's related to that area, then we have a good chance. And this would need to be from somebody who does a lot of this treatment, understands the structures, understands what can be done. You can't just put Shockwave on, in my opinion, you can't just put Shockwave where the rectal prolapse is and then be like, oh my gosh, okay, I'm expecting this to heal. No, that's not how it works. Somebody understands why prolapses are there, what's going on, what the surrounding structures are dealing with, all that type of stuff. That's perfect, because then you can take the mechanism of action, which is increasing blood flow, modulating inflammation, adjusting, scarring. We talked about, how it changes kind of the cellular structure at times. So if I can think that those things are going to help based on my knowledge of anatomy and the diagnosis in front of me, then yes, it can help to a certain extent, depending on what the issue is.
Very cool. Back to the terminology extra corporeal. All of the therapies I understand right now are external, correct?
Yeah.
And do you feel like there ever could be or would be intravaginal? Could there potentially be even more benefit to get deeper into the tissues or access more tissues? Yep. You've already said that does it address the 3 layers, what you're currently doing? Maybe it's not needed. I don't know.
So when I first started using this, I'm like, oh my gosh, we have to have an intravaginal probe. We have to have one. And then I thought, Well, why? I mean, patients would rather we not do anything internally because
Right.
it hurts, right?
Yeah.
So, but there is something that after they are able to sustain intercourse or anything, internally, then potentially, yeah, maybe it would have some good application for those types of things. So we're thinking about Softwave's, the manufacturer in Germany is thinking about coming up with one. At this point, it's like, oh, we don't necessarily need it because patients don't necessarily want it or need it. There is one probe out there that does do intravaginal, but it's either electromagnetic or piezo, so it doesn't get much depth, right? And if you use it before, in my opinion, if you use it before you treat externally with like Softwave or Shockwave, again, it's going to be really, really painful for the patient, right?
Yeah. Yeah.
Vaginal ultrasounds are like, nobody wants to have that when they have vaginismus, dyspareunia, things like that, right? We
Yeah.
want to avoid that. So
Yeah.
could there be an application down the road? I think absolutely. With the electrohydraulic, it gets steep enough that we just don't really need it at this point. But that's
Right.
something that's being thought about, especially for things like, I think about like primary ovarian failure. Yep. Can we treat externally above where the
Yeah.
ovaries are? Yeah,
Yeah.
absolutely. And I have, and we've worked on loosening up, scarring around those areas. Absolutely. But would there be more? What if we could stimulate the ovaries to bring more blood flow to and people have POI? Could we, get their body producing eggs again? I mean, I don't know. In combination with hormonal therapy, who knows? These are all questions that are exciting to now think about because of this mechanism of action of this device.
Totally. Could somebody have the treatment if they have an IUD or a pessary inserted? So an IUD is obviously going to stay there. A pessary could potentially be removed
Yep,
by the person.
correct. So I always tell patients, yes, you can. There's no this, at least with our device, the one that is more spread out like a flashlight. When I asked the manufacturer about that very question, they said there's no reason it should damage the device or should have any problems with it. But I always say to patients, we're also softening the tissue around the things that are holding these devices in place. So I always say things like, I want you to use another form of contraception. I want you to, if you feel any discomfort or whatever in between sessions, we might need to get it checked, to make sure that the positioning is right. I've treated many patients with that, with both pessary and IUD, and haven't had any issues. But I still always have that conversation because,
Right.
it's possible.
Right.
So that's kind of the precaution, not a contraindication, but more of a precaution.
Yeah. It doesn't sound like there's any downtime to this.
No,
Like
shouldn't be.
you could,
Yeah.
you mentioned your patient who was able to have intercourse, I think after 5 years, you said. And so that may not happen after that very first session, but you wouldn't need to wait to insert a tampon or put your pessary back in or
Correct.
anything like that.
Correct. Yeah. That person, a lot of times the person feeling really good after that first or second treatment, especially if it's dyspareunia vaginismus and that whole like fear of pain, right? That whole biopsychosocial response. Sometimes maybe they could try because they don't think they have a lot of pain or the dilator size we've used is much higher, but there's that confidence level too. So I always,
Yeah.
that coaching of, okay, it feels better. It doesn't mean you have to have intercourse, right? So,
Right.
kind of work up to it, and then you just kind of have fun with it with your partner, and make it more of a relaxing, enjoyable experience than one where you're like, oh my God,
Right.
it's going to hurt, right?
Right.
So
Right. Right.
a lot of the same things we do as far as coaching patients when they're, if they've needed 15 treatments, I'm doing the same in the second and third treatment because they're nervous to have intercourse because it's been so painful.
What's the typical cost of a session or a package of sessions? And is this something that potentially somebody's insurance could cover?
So right now in the U.S., there are CPT codes for it, and insurance is not paying. And I think ED, there's some exception. Softwave actually helped
Of
pioneer
course.
the first, right? Exactly. What we talked about before, about men versus women stuff. So ED, there is a Shockwave to the corpus cavernosa that was actually pioneered by Softwave to get that pushed through and get the CPT code. And there are occasional places around the country that are getting some reimbursement from it. However, there is also a CPT code for ortho, just musculoskeletal, and very few, if any, are getting reimbursement utilizing that. So at this point in time, insurance doesn't cover it. And here's what I think why. Because there are so many different devices. There's the radial device. That's not even Shockwave, but that's under ESWT. And insurance, they basically barely know anything about anatomy, or probably don't know anything about anatomy, even though they're making decisions about it. And they don't know, they see all the protocols have, some is 1,000 shocks, some is 5,000 shocks because of the different devices. Some of the protocols are, the person's better in 3 or 4 visits. Some it takes 15, 20, so it's all over the place. So it's a great excuse for insurance not to cover it.
Right.
As we get more research and the protocols become more standard, hoping that, that will change. But at this point, it's usually a cash-based practice. The exception is wounds. Wounds do have some reimbursement. If you utilize them in correct sequencing with other treatments, you can get some reimbursement if people do wound healing. But at this point, right now, it's cash-based.
Yeah.
And the average,
and what's the
average
Sorry, go ahead.
cost? It could be anywhere between, $50 to $75 a session, which is a very, very, very low end, up to, ED, because you're using a lot of shocks, to at $600 a session. So most people physicians are usually up from $150 to $200, $300 per session. Me as a PT, I'm somewhere between, $120 and $175 per session. But I'm including, actually, it's probably around $150 on average. I'm including PT with that as well too. I do less manual therapy. So it really depends. I tell people it needs to fit your business model, right?
Right.
So some people will buy it, bring it in, and raise their prices across the board, whether people are getting Shockwave or not. So that would also help them increase their revenue. And then some people just say, okay, we're doing this, you're doing great, but if you want to accelerate your healing, we can add Shockwave in, and that's an additional $100. What's nice about that too, Kim, is it's not $100 for an hour and 15 minutes. It's still $100 for an hour of treatment because it decreases your manual therapy by half.
Yeah.
So you're still able to do the same within that hour time frame, or 45 minutes or 30 or whatever you do.
Yeah.
So the pricing really varies. And a lot of times some people charge per shock. Some people just charge a flat fee.
Oh, wow.
So again, when I help people who are deciding whether they're bringing this into the clinic or if they have brought it into their clinic, I'll help them go through what's your business structure now, because it has to make sense with that, right?
Yeah.
And then we kind of build in and make sure that because the revenue can be a nice addition to the bottom line, whereas reimbursement's not going up. So bringing in these cash-based services significantly improves the ability to stay open, as a clinic.
Before I wrap up, if somebody was looking for a treatment and they're not in your neck of the woods, would you say preferably to find somebody who is offering the Softwave version? If we're obviously we're being very pelvic centric here,
right?
In this conversation, so Softwave seems to be the preferable one. And is there, do you find that there are more practitioners offering this, and is it something that's offered now, as you said, even like med spas are offering it, so it doesn't even have to be a pelvic PT per se that's delivering this?
Right. Great question. So so there are, as long as it's within their scope of practice to treat the genitals, if they have Softwave, I love Softwave, so I'm a bit biased to it, but I also like how it works, and that's why it makes more sense to me to use on the pelvic floor.
Yeah.
However, if somebody has the piezo or electromagnetic and they again have that in their scope of practice and they treat the pelvis, certainly they would be people to go to as well to get treatment. What I would say is that you want to, if you do go to a med spa or a chiropractor that could treat, that has the device, or an NP or PA, I always encourage them to partner with a pelvic floor therapist, whether it's a PT or OT or even a physician or whatever, that understands what they're doing, so that they can have that treatment along with it. Because it just, we're showing this in the study, and it just enhances their results. So even if they don't do that themselves, for the patient's benefit, to be like, okay, let's partner up with this person. They may not have the device, but I'm going to refer you to them to do the pelvic PT along with this, because it just enhances that the patient's experience.
Yeah. And the course that you've created with Herman and Wallace, is that a continuing education, or is that actually, does somebody take that to get certified to be able to deliver Shockwave?
No, it's a continuing education course. The next one's running in October 2024. And it's a remote course, which is nice. So it's really beginner. Like, you either have a Shockwave device, true Shockwave device, you want to know how to utilize it. You're trying to decide, you're as confused as I was when you go into the research and you're like, what the heck? I don't understand that. You're getting inundated by salespeople to say this, that, and the other device. In that course, I talk about all true Shockwave devices and why radial is not, and even some of the things I've now added. Some studies that are out on radial, there's just not a lot in pelvic health because of the reasons that we talked about before. So I try to be as unbiased as possible and say, here's the information. Now you can go and talk to those reps. You can decide which one is best for your clinic based on what you treat. And now that you understand what Shockwave is and what Shockwave does. So it's really a great overview, and people can walk away from that and then talk to the different companies, talk to me about my experience, and decide on their own which one is best for them.
Very cool. Where can people learn more about you? So we've talked Herman and Wallace will have that course, but you as a practitioner, if somebody wanted to potentially come to Milwaukee and work with you, where can we find more?
Sure. My name of my company is New You Health and Wellness, so they can go to newyouhealthandwellness.com. That's NEWYOU, healthandwellness.com. There's what we treat, how we treat on there that they can click on. Our blog is up. We're going to be starting a podcast next month. I'm releasing a book this fall called The Pain-Free Formula. So that'll be available
Amazing.
We'll be talking about other, what we do in PT, but then expanding that out to the functional medicine stuff that I talked about before. So if patients aren't getting better, what else can we do to manage and help them get better? So that's coming out in the fall, so they can look for that on Amazon at some point, fingers crossed. And those are the places for me.
Amazing. Thank you so much for sharing your knowledge. I've learned so much that I really knew very little, and you've really expanded my knowledge. Thank you so much.
No
and
problem.
I know that this will benefit my listeners greatly.
Absolutely. Kim, thank you so much for having me. I love this. I really enjoyed it. And when I start my podcast, I'll be reaching out to you. Okay.
Thank you.
All right. Thank you.